So we're going to talk about testing, the story of testing. So let's start off with some basic information. So one concept that we have to understand is many times we actually don't test for something exactly. We test for something similar. So when we say we're measuring your sodium level in your blood, we're actually not measuring your sodium level. We're measuring something that correlates pretty well with your sodium level. The reason for that is because testing is actually a very complicated topic. And part of the issue with testing is we have to be able to do it in a way that's sort of feasible, cost effective. So if it takes too much in terms of personalized work for the lab tech, or if it takes too much in terms of reagents or this or that, then it's just too expensive. And the other thing is whether it scales or not, because if you want to do a lot of tests, you have to do something that scales. And if each test needs one person and you want to do 100 tests, you can't have 100 people working in a lab. That's just, I don't think we even have that many people available. Let's go back to something very basic that we talked about before, pneumonia. So when we say somebody has a pneumonia in a hospital, we oftentimes don't actually know that they have a pneumonia because we don't actually verify by sticking a needle into their lungs and getting a sample and seeing if there's bacteria growing in it. We base it on other factors, and it's just sort of a guesstimate, right? So, well, do you have a fever? Do they have a white count that's elevated? Do they have findings on their x-ray that look like a pneumonia? If they have 2 out of 3, let's say it is, right? We give antibiotics and it's easy enough. We consider it a risk-benefit trade-off. Sometimes we get a sputum sample, but oftentimes there's no point because it's not cost-effective getting sputum samples for everybody, and oftentimes you don't get anything. Because they're supposed to give you a sputum sample from your lower respiratory tract, and many people just hack something up and it's called spit. It has lots of bacteria, and it doesn't mean anything. So they have quality measures to see whether it qualifies for being from your lung versus just from your throat. And so that's what testing has to involve, quality control as well. So when we say testing, you're doing testing for something else, we say test by proxy in a sense, right? We're testing something else that will give us a clue whether or not you have this or that. For example, people sometimes, interns, shall we say, hopefully as a resident you would know better, sometimes do a CD4 count to see whether somebody has HIV. This was before when you were supposed to get consent for the patient to give you a test for HIV. So that's sort of gone by the wayside now. You could just do HIV tests for people. But you do a CD4 count because if it's really low, you think it could be because of HIV. Unfortunately, there's other reasons CD4 counts could be low. Like if you have infection, oftentimes it's low. But that's sort of a test to try to do a workaround when you can't test for HIV itself. Now, for the coronavirus, it's pretty important that you get this right. So they have something called PCR, which is, quote, the gold standard. So the gold standard in the medical field doesn't mean it's right. It just means it's the best we have. Like gold was the standard. Doesn't mean gold is the most valuable thing. Doesn't mean gold keeps its value. If you've been watching the market, gold prices have actually gone down. What it means is it's the best we got. So we use it as the gold standard. And so reverse transcriptase, PCR, polymerase chain reaction, is our gold standard. There's other methods too. Immunofluorescence, you do monoclonal antibodies, you try to get them to attach these antigens on the virus. And then that are particular to this specific virus, the coronavirus. And then you look at them sort of under fluorescence or they light up somehow and then, detect and see them. And then there's also antibody testing. So let's talk about PCR first. So you need reverse transcriptase because coronavirus is an RNA virus. There's DNA viruses and there's RNA viruses. Viruses are very simple creatures. They're sort of, I would say we consider them alive. Generally speaking, whether they're alive or not, who knows? What is the definition of life? But they do replicate. I mean, prions are sort of really scary, or whether they're alive or not, because they're just proteins and they manage to affect other proteins. So we take this RNA and we magnify it and we make a lot of it and we see if it matches to our sequence that we have for the coronavirus. And if it matches, we say that's wonderful. Now, there's a few issues with this method. One is operator technique. That's always an issue. So somebody has to get a sample from a patient and they take it from different places, but the most common one is the nasal pharynx. That's if you look at your nose and go all the way deep inside till sort of where it reaches the throat. If you don't go far enough, you're not going to get the virus. You could also miss the virus. There's something called sampling error. You may hit a spot and it just happens to be the spot that doesn't have the virus. We encounter sampling error a lot with cancer. So if you have a big mass growing there, sure, we can stick a needle in and we got it. But say you have lots of little dots on your liver. We may stick a needle in and we don't got it because we managed to miss the dot. Because there's so many dots. But there's also gaps between the dots and the needle is sort of very small. When you take a sample, the pathologist doesn't literally look at the whole sample under the microscope. They look at certain parts of the sample. They have a mechanism of doing that, but they may miss it. So there's something called sampling error. And it could be that they don't have it in their nose yet, in their throat yet. It may be somewhere else in their body first and haven't gotten up there. So there are all these drawbacks to doing that. It is the gold standard though. The next thing is there is this antibody test to antigens. So the idea is that a virus makes particular sort of, it has, have you seen the pictures? It's like the lump and it has these spiky things coming out. Those are antigens that our body reacts to. And so in the lab, they'll make these antibodies to them. They're called monoclonal because they sort of all look the same. And so you try to match it, and at the end you have a tag that will light up if it's sort of attached. So that's another way of testing it. But there's obviously issues with that as well, because maybe they're reacting to something else that we didn't expect. Because they're supposed to be specific, but we all know how specific things really are. For example, there's something called a PSA, the prostate specific antigen. It's supposed to be a marvelous test for detecting prostate cancer. Well, some women have a PSA level that's detectable, and they obviously don't have a prostate, so it's obviously not the most specific thing in the world. And the last method we'll talk about is antibody testing, testing for resistance. So we know in other cases, the antibodies don't necessarily get formed right away. And now we also seem to know that some people don't really seem to form much in terms of antibodies. But presuming somebody did form antibodies, we could test for those antibodies and see whether they have them or not. And this is useful, people think, in more than one way, because we don't just want to know whether somebody has it, we want to know whether somebody is immune to it, whether they've gotten over it. And the basic rule is we have two forms of antibodies, IgM and IgG. IgM are acute phase antibodies created to fight infection here and now. IgG are antibodies for the future. They have a memory. They'll help you in the future. They mean you had it before. And so we want to see IgG antibodies. IgM means you're still dealing with it. IgG means they sort of resolved it. It's not really that simple. It depends on the virus. Like hepatitis B is very complicated in terms of the antibody mix. And we learn about it in school, how you have to look at, what the antibody is to. There's an antibody to the E antigen, right? There's an antibody to the core. There's surface antigen. It's just very complicated. And maybe coronavirus will turn out to be that way as well. So in the US, still currently, and China a month or two ago, testing was not readily available. So we had to go back like how we diagnose pneumonia. We have other testing methods and we try to use those to make up for the fact that we actually can't test for this virus itself. And a lot of this was chest imaging, whether it's an X-ray or a CT scan. They had a classic pattern, they would say. The problem is it's classic in that a lot of people with it have the coronavirus, but people could have other types of pneumonia and it would still show a certain pattern. So that's the problem with looking at a picture. You can't tell what's going on underneath. Like you could look and see somebody has a huge mass in their lung on the CT scan, but it doesn't tell you what type of lung cancer they have. They may not even have lung cancer. It may be cancer of another origin present in the lung. That's why we want to get a sample. And so sort of we're moving towards actually testing for the virus because people could still get pneumonia, they could still get the flu, they could still get other things that appear like this on imaging studies but are not, and we want to know the difference. Now, the next thing about testing is there is no such thing as a perfect test. In the medical field, if you are in it long enough and think about things, there's no such thing as perfection. It's all about good enough, which I understand very well because I come from an engineering perspective. See, as an engineer, you can't make a perfect program or a perfect tool because there's all these constraints at hand. There's time. You don't have infinite amount of time. You have a deadline. There's money. Sure, you can get lots of people working on it all at once, but hey, that costs money. Somebody has to pay for this. And so you sort of settle for good enough. So if you look at structural engineering, designing a lot of the infrastructure we have, a bridge does not have infinite carrying capacity. They have a threshold on it. And so even though oftentimes there's a lot of leeway for that threshold, if it says 20,000 pounds and you're 20,100 pounds, it's probably not going to collapse. But the idea is they calculate a certain tolerance and build it to that. And that's sort of the same way it is with testing. So there's something called false negatives and false positives. A false negative is saying somebody doesn't have it when they actually do. And a false positive is saying somebody has it when they actually do not. We use two things called sensitivity and specificity when we set off the cutoff. So sensitivity, I remember by the word snout, SN for sensitivity and out. Snout, you rule out. If it's very sensitive, you could rule out and say somebody doesn't have it. But if you want to say somebody has it, you have to do spin, specificity, SP rules in. So it's very specific, you could say somebody has it. But if the test is negative, it doesn't mean very much. So if you think about any cutoff, we always set a threshold. It's very arbitrary. It's one number fits all and obviously doesn't work that way. But we do some calculations and we say, this is a good general trade-off. And so if you look at sort of lab values, there's normal values for your, say, glucose, for your sodium, for this or that, for your creatinine. However, you could be not in the normal range and still be normal. Because the way we define it is 95% of the people, rather the mean, is within that range. So if you look at a fever, right? So for Celsius, it's much clearer because we use sort of whole numbers, 37, 38, 39, right? So 37 is normal, 38 is not, 39 is not, right? So for Fahrenheit, people say 98.6, but that's not really. But we use 100.4 and a 101.3. So we use an arbitrary number as a cutoff. And some people say, well, I normally run lower, so this is a fever for me. And I don't disagree that this may be higher than your normal, but we're just not going to call it a fever because we have an arbitrary definition of what a fever is. So some people use 100.4, some people use 101.3. What's the difference? Well, if you set it lower, you have more people that, quote, have a fever, and you may catch a serious infection sooner. If you set it higher, right, you'll have people that may have a fever, right, but you didn't call it a fever and you'll miss their infection. But you also have less people that have false fevers who don't really have infections. So, they try to do a number that sort of works out for both. So if you look at things like HIV, right, we actually do two tests, and this is a good point to talk about screening tests. So when we do a screening test, we're not asking for accuracy. We're asking for people to be sort of ruled out. So we should have a test that's very sensitive, right? That rules people out. But if they're positive, they still may not have it, but hey, we caught it, maybe, right? So for HIV, many times nowadays we do two tests, at least in the US. We do one test that's quicker, it's more of a screening test. And if they don't have it, we're pretty clear they don't have it. It's very sensitive. But if they're positive, we're still not clear. Actually, the test is pretty good, but we just pretend it's not. We do another test that's even better to make sure that they have it. It's called a confirmation test. So it's very specific, and it rules them in for it. So going back to talking about the coronavirus, There was a study out in China saying that CT is actually better at sort of early diagnosis than PCR. And people are like, how does that make any sense? Because PCR is the gold standard. Well, because some people may not test positive via PCR initially. It's not there in their body in a very easy to diagnose way, but they already have the findings on CT scan. And remember, on CT scan, we see damage. It could be from other things, right? But we also can't get a sample from the lungs by sticking a needle in. Actually, we can. We just don't because we think it's too high risk. You could get a hole in your lung or things like that. So we go ahead and we sort of do other testing in other parts of the body. It's sort of like temperature. The temperature that we get is obviously inaccurate. If we want to get an accurate temperature, we have ways of doing that. A rectal temperature is pretty good, but most people would find it uncomfortable. And we have a core temperature you can get directly from the heart. We have things to put in the heart. We also have ways of putting stuff in the bladder and measuring temperature that way. And when we do something called therapeutic cooling, which is often done after a heart attack to preserve neurologic function, we actually want a good way of getting temperature, and we'll stick a catheter into their bladder and get a real core temperature that way. So that's sort of the general gist of testing for this thing. So a little bit of the background and sort of the accuracies of testing. So the idea is nothing's 100%. And so there's lots of ways that people are false. And so what we say is you got to have an index of suspicion. Remember that doctor who sort of was suspicious of there being a SARS-like virus? Dr. Lee, the ophthalmologist? Later on, he got it. Well, guess what? He tested negative many times. But finally, he tested positive and he died from it. And so that's the thing that we have to realize about testing. Testing is not magical. There is no test that's perfect. It's just one tool that we use. Our brain is the biggest tool, and we have to use it and we have to think critically. There's no such thing as numbers, data. You have to evaluate things because you don't just take it alone. You take everything together as a picture and try to make some conclusion from this. Because, as we said, there's drawbacks to every test that we do. And I've just told you about some of the drawbacks of PCR, about antibody testing, and about antigen testing.